All right, I think we're going to go ahead and get started on our last session. If those of you who are still here want to start taking your seats. And if there's anybody out in the hall who can hear me, who's interested in coming back in, now would be a good time. I am acting on behalf of Jessica Berman, as she is out ill, as Dr. Patel mentioned earlier. So I am the moderator for this session as well. This session is going to be focused on treatment for colorectal cancer in Lynch, and we have two very wonderful speakers coming up here. So our first speaker is Dr. John Vogel. He's a colorectal surgeon and professor of surgery at CU Anschutz. And he's been performing surgery on patients with hereditary colon syndromes for the past 18 years. And today he's going to talk about surgical approaches to colorectal cancer in individuals with Lynch syndrome.
Well, good afternoon, and thank you for having me here. So this is me. And today I wanted to talk with you about what colorectal surgeons think about when they meet a patient with Lynch syndrome, to talk about surgical options. And we see patients in sort of two scenarios. One is they have a cancer, and the other is they don't, and they're trying to prevent it. So these 4 points sort of outline the thought process. One is appropriate treatment of the primary tumor if they have a cancer. If they don't have a cancer, then it's appropriate ways of reducing the risk of developing a cancer. When we think about what operation to do, we think about the risk of them developing a second cancer if we remove a small part or a large part of their colon. And then we think about the morbidity of surgery. Different operations have higher levels of risk for complications. I'll talk about that more as we go on. And then for female patients, we think about what else we might do while the patient is prepared for surgery under anesthesia and having a surgery. So one of the things that I think about is the genotype of the patient, because I think by now everyone here is well aware that different genotypes are associated with different risk profiles for colorectal cancer. And so I do think about this. I think about this mostly when I see patients who don't have cancer and they're thinking about doing surgery for risk reduction. And I will also think about this with surgical decision-making, and I'll sort of expand on that as we go. So now for the patients that don't have Lynch syndrome, the patients who have sporadic colon cancer, which is, obviously the majority of patients that most colorectal surgeons take care of, we know that just by removing the segment of the colon that's affected with the cancer and the associated lymph nodes is adequate treatment to treat the cancer that's present and leave the patient with an acceptable and manageable risk for a metachronous cancer. So this is an example of a sigmoid colectomy. Patients sometimes want to know when they ask me, how much am I going to be taking out? And I put my hands up and I say about this much. And they say, wow, that seems like a lot. The cancer is only this big. Why are you taking out this much? And the reason why is that we have to take out the blood vessels that supply the tumor so that we can get the lymph nodes. We need to get the field of lymph nodes that are associated with the segment of colon, which go along the blood, the blood vessels that supply the tumor. And I say, don't worry that we're taking out a piece this long, because your colon's really about this long, and you're really not going to miss a small segment. It really doesn't have any long-term negative impact on quality of GI health. Now, would be an example on the left side of the screen of a right colectomy for colon cancer. And again, it's that larger segment of the colon that's necessary to be removed so that the draining lymph nodes can go with the the specimen. We call that an oncological resection. So on the left side of the screen, it's a right colectomy. On the right side of the screen, it's a sigmoid colectomy. If we do that in patients with Lynch syndrome, we know that their chances of developing a second colon cancer, colorectal cancer, over the next 10 years is around 10 to 25%. And that's even with good surveillance. You know, in the studies that are listed up there, these are patients who have been, that have, with known Lynch syndrome, that have undergone colonoscopic surveillance every 1 to 2 years. And so they're not patients that are really falling through the cracks. It's just, it can be hard to find these polyps before they turn into cancer. I think that's probably going to get better as the years go by, as endoscopies get better and high definition imaging is present and other ways to detect cancers. But this is where we are as recently as a couple of years ago. And so what other option can we do? The patient has a right-sided colon cancer, they have Lynch syndrome, and we talk about doing either just a segmental removal of the right side of the colon or doing something more. Well, it turns out that if a patient comes in with a right-sided colon cancer, a sigmoid colon cancer, a splenic flexure cancer, if you look at the United States Multi-Society Task Force guidelines and the American Society of Colorectal Surgeons guidelines, both of those societies recommend doing a total abdominal colectomy. I mean, moving essentially about 80% of the large intestine and then joining the small intestine to the rectum. Okay, it's not such a hard operation to do. It's really just sterile plumbing work. But the problem is that it is associated with a higher risk of complications of surgery. And it's also a quality of life changer. Because I think many of you probably know the colon doesn't do much aside from absorb water. It turns liquid waste into formed waste by absorbing water. That's pretty much it. And so what happens in this situation is you get liquid waste delivered into the rectum, and that is associated with more frequent bowel movements. 3-4 bowel movements per day is good. We don't see that until about a year after this operation. It takes a long time for the ileum and the rectum to adapt and to be more absorptive. We know in doing this operation, it really reduces your risk of developing another cancer. However, it doesn't make it zero. And you can see studies have shown that up to 8% of patients who have this operation will subsequently be diagnosed with a rectal cancer. I told you what the United States Multi-Society Task Force and the ASCRS would do. The UK guidelines, which were more recently published, took a slightly more nuanced approach. And they said, you know, if the patient has an MLH1 or an MSH2 defect, then yeah, we feel like we can make a real good case for doing a total abdominal colectomy with ileorectal. But in this setting of MSH6 or PMS2, they say, you know what, we can't make as strong a recommendation. And that's something that maybe we can talk about later. For patients with rectal cancer, now you're faced essentially with two options here. Do you just remove the segment, the rectum that's affected by the cancer, as you would do in a patient with sporadic rectal cancer, and leave all of this healthy colon, or do you do something more? So in sporadic rectal cancer, we just remove the rectum, the surrounding lymph nodes, we join the colon to the rectum. It's not such a life changer because you're leaving the rectum, and leaving the rectum is essentially the critical part of good bowel function. So, but how about in Lynch syndrome? Because that's really what we're talking about today. What's the risk of developing a second cancer? And should we do a segmental resection as we would do in a sporadic patient? Or should we remove the entire colon and rectum and give the person an ileostomy or do something called a J pouch? And this is a big decision, because quality of life, if you take out somebody's entire colon and rectum and give them an ileostomy, they're going to have a very normal quality of life, but it's going to be harder. It's going to be harder to go skiing and to go running and to go camping with an ileostomy. It's also going to be harder to do those things with a J pouch. J pouch allows you to avoid having an external bag, but people who have J pouches on the inside are going to the bathroom 6, 7, 8 times per day, one time at night. So I guess what I'm getting at is by removing the entire colon and rectum in Lynch syndrome patients with rectal cancer, it really is a dramatic change in quality of life. So if we just take out the rectum in Lynch syndrome and leave the colon, then what happens in terms of risk? Well, these two authors looked at their experience. Kalady and colleagues looked at the experience from the Cleveland Clinic, and Wynn and colleagues looked at their experience and found that patients who had just a rectal resection kept the colon at about a 15 to 30% risk of developing a metachronous cancer, increasing with time. So again, obviously, these patients need to be watched very closely. In terms of guidelines, the American Society of Colorectal Surgeons recommends just treating rectal cancers as you would in a patient without Lynch, because of such a dramatic quality of life change. And I guess what's thought of as an acceptable risk of metachronous colon cancer. But again, that's another thing that might be a good point of discussion. I wanted to just get in briefly. This is an area, I'm not an oncologist, but this I find this topic pretty exciting. These are a new pharmacological approach to treating colorectal cancer with drugs that are called checkpoint inhibitors. They're advertised a lot. Keytruda is the trade name for the drug pembrolizumab, which essentially allows the immune system to do its greatest battle against cancer cells. Cancer cells are trying to block the immune system from coming and gobbling up the cancer cells. These PD-L1 drugs are on the side of the immune system. They're helping them out. They're allowing them to go in there and devour cancer cells. This is really an exciting topic. This was a study that came from Memorial Sloan Kettering that looked at PD-1 blockade in mismatch repair deficient rectal cancers. There was no patients in this study with Lynch syndrome, but just to make a long story short, they treated these patients with these nasty rectal cancers just with this checkpoint inhibitor drugs, and they found that all of the patients, their cancers completely disappeared with checkpoint inhibitor therapy. Not one patient to date has had radiation or surgery. And so this is another really exciting sort of area of patient treatment and research in colorectal cancer, and it's going to play a role in patients with Lynch syndrome. When I take a patient with Lynch syndrome to the operating room to do a segmental or total colectomy, I'm also talking with my female patients about uterine and ovarian cancer risk reduction. I know that topic was covered earlier, so I'm not going to go over it again. I will tell you that the society that I sort of follow most for guidelines, again, which is the American Society of Colorectal Surgeons, their recommendation is that hysterectomy and bilateral salpingo-oophorectomy should be offered to women with Lynch syndrome undergoing colectomy, particularly if they have finished childbearing. And so to wrap it up and summarize, colorectal surgery considerations in Lynch syndrome, we're thinking about treatment of the primary tumor and how do we enable the best chance for risk reduction for a second cancer, and how do we try to have as little impact on the person's quality of life. I didn't really talk about prevention. I just recently operated on a patient who has Lynch syndrome, does not have cancer, has had a real difficult time with preps, colonoscopies, complete colonoscopies, the inconvenience, expense, and whatnot, and decided at the age of 42 to have a colectomy with ileorectal anastomosis. And obviously there's select patients who that is the most appropriate way to go. We talked about considerations of second colorectal cancer risk reduction, the morbidity and quality of life associated with different things we do, and then lastly about uterine and ovarian cancer. So that's all, and thank you. I'll turn things over to Chris.